just we have, when we talk about cardiogenic shock patient, we have many challenges we have. The use of temporary mechanical circulatory support, we see that many devices, we have many tools. We don't have only one tool like we have in the past. And we have, there's no randomized trial. We have publication bias. We have many publication now in acute MI shock. We have some publication now in acute on top of chronic, but we have some other group which is not appreciated, like patient in septic cardiomyopathy, patient with other etiological factors for cardiogenic shock. And shock team and networks are lacking. It's not everywhere you find shock team, and you find networks now to help getting access for some patients struggling from shock in a peripheral hospitals. And daily decisions are based on personal or institutional experience and the financial burden. We still have the cardiogenic shock mortality is still high. We know that the effect of early initiation of MCS or temporary mechanical support is improving the outcomes. As you see the data here, the number of drugs is not, if you're increasing the number of inotropes, the mortality rate is increasing. Also, the etiology of cardiogenic shock, as you see in 29% from our experience, are not related to acute MI shock and not related to acute on top of chronic. And this here slide is reflecting the tremendous increase in utilization of temporary mechanical circulatory support in the last years. But how is the real life data looks like? When we look to the patient presented in SCAI, and according to SCAI classification and how they were supported with mechanical circulatory support, it's important to know that patient in the SCAI E was requiring more, here's this lower part from the slide, the SCAI E. Most of the patient required more than one system, Impella Plus or ECMO Plus. That means one system alone was not capable to achieve the goal. What does it mean? It means that we have to start to think about the goal-guided therapy to see how we can achieve our goals on this patient and how we can start to think about which device we should use on those patients. From our experience here in Oklahoma, we have in our shock network, we have more than 966 patients. We see that started to use Impella 5.5 in few years ago, and we have 60, we have more than 100 patients now. But in patients with in class D and E, 25% require more than one system. That's now is guiding us to say we need to think about algorithms to guide us, to guide the clinician to see which patient for which, or which system for which patient, and how we can escalate and de-escalate. And when we talk about escalation, we talk about initiation of temporary mechanical circulatory support for cardiogenic shock patients. That's the first decision, see when we are going to move from medical therapy to escalate to the first step, mechanical circulatory support, or transitioning from one system to another, or escalating one system and adding one system. When we're talking about de-escalation, we talk about weaning or subsequent explantation of one or more of those systems. We have, as you see here, the slide is we have multiple tools, multiple toys. We can play with them for right ventricular support, for LVAD support, for BiVAD support, for pulmonary support. And you have the slide here also reflecting the different features from each device now, how we are going to unload, Impella is unloading the left ventricle and improving your, decreasing your left ventricular end diastolic pressure, reducing your LA pressures. Tandem heart had different feature, and we have to understand the feature from each device. If you have them here before, it is going to help you and guide you. If you don't know that, you shouldn't start with them, because that's a basic principle. You have to know how those devices are going to make changes in the hemodynamics on the patient. And that will help you to guide you to go to the next step to see which device you will be able to use in which condition. Well, We know that also that one of the facts that the acute MI shock is happening everywhere. It's not happening in high volume centers. And we know that the majority of patients got the PCI in low volume center. What does it mean? Mean now we have to work in a hub and spoke, and we have to work to get to open the access for patients who are struggling from cardiogenic shock in a referring in a remote hospitals. Does not have all the tools. All might they have the Impella CP, but if Impella CP is not going to do the job, how are you going to escalate to the to the other level of care? And I'm glad that the Society, the American Heart Association, started to propagate for that, start to say that's the way we have to go in the future to work in a hub and spoke model. And that's what we did in Oklahoma. Now, when we're talking about that, I think that the patients in class C and D should be, that's the time to move those patients to centers which we have the capability to monitor those patients, to manage those patients, and to take a decision about escalation of care to go for the next level of mechanical circulatory support. Why I'm saying that? Because those patients need monitoring for many things. You need lab, you need echo, you need to have a swan on them, and you need to get complete hemodynamic monitoring for those patients. That means you need a team working on those patients 24/7. Some of these parameters, you might need to do it in every hour or every 50 minutes to monitor the patient and to help you to take the decision to see now is the time to escalate. If you're not moving this patient to this hub center, the mortality rate will not be optimized. And we know also from the CESAR trial, which was conducted in England in utilizing ECMO in ARDS patients, that moving patient with ARDS to hub center without placing them or escalating the care on those patients improves the outcome. That's why moving those patients to hub center, having the infrastructure to be able to monitor and to address the needs of those patients is improving outcomes to take the decision in a timely way. That's again that you need to monitor the all organ function of them, kidney function, liver function, respiratory function, neurological status, and complete hemodynamic monitor of this patient. And again, the data you are collecting from this patient, some of them you might need to collect them every 50 minutes or every hour just to help you, to guide you to take the decision in a timely way. Time matters. Why? That's here because we know that if you keep the patient longer term in cardiogenic shock, that's going to trigger the cascade of bad events will happen to the patient. You're going to end up with multi-system organ failure. You're going to end up with sepsis, and you will not have good success on those patients. That's like what we learned from the guys with trauma and shock. They have the golden hour, and we have golden few hours to react and to try to support those patients in a timely way. If we are not achieve those patients in a within few hours from the onset of the onset, we are going to struggle from many other complications of those patients. You're going to have kidney failure, you're going to have shock liver, you're going to have severe vasoplegia, and you will not end up with optimizing the outcomes of those patients. The slide here showing us also that the outcome of this patient, when you apply the mechanical circulatory support, after 4 hours, the mortality rate is more than 70%. That's why its times matter on those patients. That's why when we talking and going to talk when to escalate the therapy, when to think about mechanical circulatory support, we will think about patient now, if you have the cardiac index is below 2.1 and lactic acid is started to go above 3 despite 2 inotropes, it is the time to think about it. We try to simplify that. SCAI classification is great, but might be needs in-depth understanding and might be to need people working in high volume center to understand all the levels Yeah, but if you simplify that to be 2 inotropes and escalating lactic acid, everybody will understand that at 2 o'clock in the morning and will react accordingly. We simplified our referring criteria because of that, and we said, guys, if the patient now requiring more than certain level of inotropes and lactic acid above 3, refer the patient to the hub center. It make it to try to simplify it, because if I'm talking at 2 o'clock in the morning in another with somebody referring patient to us and ask him about Sky E or C or D, whatsoever, he will not be able to get me clear answer to that. That's why we try to make it more practical for centers does not have all the expertise we have here to manage those patients. Now, when we start to try to think about mechanical circulatory support, in the past, when we have in the field of durable support, we have many devices, and we started to have algorithm which patient should get which device. We started to think about that also in a field of acute support, because we have too many tools and we have different patients at their presentation to us. We have to look to the patient characteristics, first of all, and type of support needed. Is the patient need LVAD, BiVAD, or RVAD? Is intent of treatment, is this patient now going to be in a recovery, or a patient now acute on top of chronic heart failure might go for advanced heart failure therapy? All that factors will help me to select the appropriate device for the patient. And time of intended support. Is the patient now is going to be 7 days or weeks? If I have a patient with myocarditis and I expect recovery, it might need 4 weeks, 6 weeks, or 8 weeks to recover, rather than the patient with acute MI shock might need few days for support and then will recover. That's why it is important to know what's the intended support time. And devices available and time. If I have the expertise I have here, I have surgeons who are available 24/7 to do everything, or I have limited access to the technology. All that's going to help us to guide me to see which device I can do for the which patient. And I have here the 2 case scenarios. If you look at this 2 patients with acute MI shock, but one of them had a central venous pressure of 11, lactic acid of 3.5, and he is in moderate doses of inotropes. If you see to the right side of the slide, the patient now is acute MI shock, but has central venous pressure of 22, lactic acid of 10, and wedge pressure of 28. This both patient, I cannot put probably Impella in the first patient, but the second patient is struggling from biventricular failure. He might be and started to have metabolic problem associated with that. That is all that the 2 cases I would certainly not put the same device on them. That's the etiology was acute MI, but the different presentation. Well, the goal for us, and we have to put that in front of our eyes in every case we're talking about. I would like to restore the circulation. I would like to get the wedge pressure down. I would like to get the central venous pressure down. And I would like to escalate the inotropes or pressures the patient have. Which device is going to give me that goal and achieve the goal I'm going to go with? And based now in the hemodynamics of the patients, I will pick the right device for the patient. It's important to understand the principle, to understand how the device is going to have hemodynamic changes of the patient, what's the hemodynamics of this patient, and what's my goals for this patient. That's very important point and going to guide you to select the appropriate device. And again, when you put the device now and you see you didn't achieve the goal, we put a patient now in Impella CP, but despite that, the wedge pressure is still high, the CVP is still high, and we're still requiring inotropes. That means I have to think about the next step on this patient to see I need to escalate to 5.5, or I need to escalate with right ventricular support based on echo and the central venous pressure and my pulmonary artery catheter data. I have to think about that. If I see patient on ECMO and I still have the wedge pressure is high and the left ventricle is distended, I have to think about now how I am going to escalate that with adding Impella CP or Impella 5.5 to decompress the heart and achieve the goals. That things we have, it requires close monitoring to the patient and there's a minute by minute management of those patients to achieve your goals. Well, now when we put the patient on support, and I'm going to simplify that with this slide, and when we put the patient on support and achieve the primary goals, that means achieve the hemodynamic requirement. And we started to see the patient started to recover. The inotropes are down. We got his volume overload down. We got his kidney started to recover. Liver started to recover. And we see the echo, with the serial echo we do that, you see the echo, the heart function still started to improve. Now we're going to start about how we're going to wean this patient. The way we are weaning this patient, we have our weaning protocol and is working for ECMO, and we modified that for Impella 5.5 patient. How we are doing it? When we see that the patient achieved an ejection fraction of 25% and his requirement for inotropes went down to below 0.05 of epinephrine or equivalent, and his mean arterial pressure above 65 and wedge below 18 and central venous pressure for 15, we are going to conduct the so-called ramp down trial. That means we are going to put swan on a patient and do an echo at the bedside and get the basic hemodynamic measurements on full ECMO support and reduce in a stepwise the ECMO support by 25%. And every step we go down with getting echo again and with getting the complete hemodynamics. And the patient remains stable despite the reduction of the ECMO support. From a step to step, we are going to reduce the ECMO support further till we reach the level that we can clamp completely the ECMO. We give the patient 2,000 to 3,000 units of heparin and completely clamp the ECMO support. That means the patient now is completely off ECMO for 4 to 5 minutes. We get the echo, we get the complete hemodynamic, and if the patient, despite the stop of ECMO, have the following criteria here, is that ejection fraction above 25%, mean arterial pressure above 65, wedge below 18, and central venous pressure below 15, and cardiac index above 2.4, we say the patient is weanable. We do that in two times, and with a period of time in between 12 hours to 24 hours. If the patient fulfills this criteria, the patient is weanable, and that's in about more than 85% from the patient. If it's an acute MI shock, we have sustainable weanability and recovery in those patients. What we've done, we cannot say if that's valid for patient in acute on top of chronic heart failure. We need more data on that, but it's working. We're modifying that in a similar way for Impella, and it's working as well. That's really my last slide, and I hope it is on time. And that's, again, I would like to stress how important is the team and team building to help you to manage those patients. Thank you for time, and if you have any questions.